It's a pleasure to be with you all today and to be in conversation. Um, and you may have seen a show on Renee Bach. I think it's on Netflix, but I'll just begin our conversation with that story, in case you are not familiar with her. So Renee Bach is a 20-year-old high school graduate from Virginia. She has no medical training. She took it upon herself to establish and run a center for severely malnourished children in Uganda, wherein 105 of the 940 children under the center's care died. Her decision to found the center came from a volunteer missionary trip where she had, quote, a very, very profound feeling and experience, and felt, quote, that there was something that I was supposed to do, unquote. The audaciousness and exceptional nature of her actions, which resulted in the deaths of already vulnerable children, is intrinsically linked to long histories of drop-in missionary trips and white saviorism in colonial and tropical medicine. Her actions also reflect an unspoken assumption in global health that whatever is one's qualifications, they must be more than those of the indigenous population. Moreover, Vox Cruz was able to continue for 5 years, in part because of these longstanding practices from aid organizations, which routinely parachute doctors in and out of countries in the global South. The legacy of inequity in global health is such that even if you have never worked in global health, the color of your skin, the accent of your voice may unduly confer upon you a level of authority in communities that have internalized coloniality, such that foreignness connotes expertise that you likely don't deserve and shouldn't have. The continued persistence of coloniality in multifaceted forms has had devastating effects in global health, and we see this in a number of different spaces, which I'm going to highlight in my talk with you all this afternoon. One, we see the continued sort of thinking that there was a need to save uncivilized, ignorant natives from themselves. Global health, which is has inherited from tropical and colonial medicine, the sort of top-down dynamic, the supplanting of local systems of knowledge of production. And as we were just talking about, focuses on these biomedical once-off solutions, these tech-heavy solutions, as we were just talking about, as sort of quick fixes, as opposed to sort of anything structural, which would requiring a more health justice-oriented approach that's aimed at undoing and addressing the underlying social determinants of health. So the current tendency, for example, to emphasize individual responsibility also harkens back to colonial and tropical medicine that tended to blame natives for their ailments and their diseases, as opposed to inequitable resource distribution or anything structural. And so we've seen this in a couple of different instances. For example, with the Ebola epidemic, where there was a tendency again to blame marginalized populations for being non-compliant and facilitating the spread of disease, which obscured geopolitical and structural factors that facilitated disease transmission. There is the continuing pattern of top-down dynamics from colonial approaches to tropical medicine in how countries and researchers in the global North and South work together with the excessive influence that researchers in the global North have, power, privilege, and control over resources, which essentially dictate the global research agenda, and can in some ways mimic a dynamic in which global health, what's important in global health, is dictated by those who are far away from the scenes, where those who sit in boardrooms far away in the global North are responsible then for setting the health agendas miles away, with no real significant involvement of local leadership. And so I want to talk about this legacy in the context of a reform initiative that has been taking place in global health. And my remarks at the outset should make clear that I view global health as something that cannot and shouldn't be divorced or decontextualized or depoliticized from its sort of historical roots and governing logics, right? Global health, through both a mission and commission, furthers inequalities, hierarchies, and subordination. And we can think about how the field operates both in theory and practice in ways that continue the devastating consequences um, of colonialism, right? So global health can either work to upend and undo these hierarchies of structural racism, colonialism, class hierarchies, and other forms of subordination in health, or it can ratify or exacerbate them. Instead, when we think about global health and how it engages with inequality, it tends to do so sort of shallowly, right, as a function of income disparities between states. You are likely familiar with monikers like low income and middle income to describe different countries, as if how countries became low and middle income are divorced from how countries became high income countries. And so this practice sort of routinely diverts our attention away from attempts to historicize or contextualize how structural inequality is created. And so this is creating sort of a silence in global health. In 2015, member states of the United Nations agreed to an urgent call for action. All 191 UN member states agreed to what's called the Sustainable Development Goals by the year 2030. And those goals cover a host of things, one of which is ensuring healthy lives and promoting well-being for all at all ages. And there are 13 targets that focus on health. Which includes achieving universal health coverage, including financial risk protection, access to quality, essential healthcare services, access to safe, effective, quality, and affordable essential medicines and vaccines for all, as well as ensuring universal access to sexual and reproductive healthcare services. The project to date has made insignificant progress on a host of sustainable development goals, including the ones focused on health. And there's a powerful sort of need to recognize the ways in which countries who are supposed to be galvanizing towards addressing inequality in health and in other spaces have sort of failed miserably. And we need to kind of understand why we see that. And so 2030 is approaching rapidly, right? 5 years from now. States and other actors are supposed to be sort of assessing, okay, what happened? Why didn't we meet the goals? Why didn't we meet the targets? And the UN has been warning in several dire reports that, the pace of change is not fast enough, is not deep enough, that states haven't done enough to change global health inequality amongst a whole host of other goals. And so the UN has been trying to urge collective action to mobilize resources in this space. But I think what's important to talk about here is that the problem is not one of scarcity, right? So the current maldistribution of resources, which has resulted in 26 people having the same wealth as half of the world's population and record levels of inequality. I was reading today that Musk is set to be, literally the richest person ever to have exist, having billions of dollars, enough to give the 8 billion people on planet Earth a billion, and still have more left over, or several hundred thousands of dollars and still have more left over. And so this is just an example of how the seen levels of global health inequality that we're seeing is structured by record levels of inequality that we're witnessing all around us, right? And so this inequality that is pervasive is linked to history of exploitation and colonialism, which we see reflected in global health, such that when there are sort of reform initiatives aimed at change in any way, we don't see any real progress, in part because a lot of the reform initiatives are not aimed at troubling any of the things that caused the record levels of inequality that we are witnessing. And so when we think about the ways in which um, the COVID-19 pandemic was a portal for us sort of to visualize um, inequality writ large, you would have thought I think at least many thought that that would have been sort of a galvanizing moment for transformative change um, in global health. And the two major reform efforts that came out of the pandemic um, don't have anything that sort of substantially addresses the challenges we all face um, with COVID-19. So, for example, there are provisions within the pandemic treaty, but they're not really stringent as it relates to sort of geographically diversifying production and distribution of health products. They don't speak forcefully on the transfer of technology or mechanisms for pathogen access and benefit sharing, which has been delayed, I think, until May 2026 to try to figure out what states can agree upon there. And the obligations that have been imposed are really sort of minimal, process related encouragements for states to sort of support, facilitate, without any real teeth behind any of them. And a lot of the obligations are framed vaguely and they're contingent. Um, and this mirrors the other major reform initiative in global health, which was revisions to the international health regulations, which was aimed more at trying to surveil and detect where there are emerging diseases, as opposed to sort of building health capacity and the like. And so there's a way in which it seems as if the project is one of generating more um, infrastructure sort of as an end goal in and of itself, right? More legal architecture, more global health architecture as an end goal itself, as opposed to engaging with whether any of the different initiatives are affecting a change in the lived realities of people across the globe. And this is, in one way, how the field sort of continues to not really make a substantial enough break from the coloniality of the past and continues to reverberate into the present. And so it's important to think about this history with the present initiatives that we face, because there are very few moments in global health history where the gross amount of inequality that we see in the world are sort of put in stark measure. And none of the recent initiatives are really aimed at troubling that. And so I'll stop here. I could go on, but I'll stop here because I think I hopefully have given you all enough food for